Good morning. Can everybody hear me? Okay, good.
Yes.
This has been a challenge for all of us. We thought we can start with a small, conference online, like many of us with the COVID-19 challenge. And we end up with 3 large panels and incredible presenters. But thank you all for joining us. Por los participantes que hablan en español, también hay un botón para poder aplastarlo y poder escuchar la traducción al español. Nuestra traductora de esta mañana es Isabel Fierros. Our translator for this morning's session is Isabel Fierros. She will be translating in Spanish the session for those members that join us from our sister cities of San Luis Rio Colorado and Mexicali in Mexico. So thank you for joining us this morning. Our panel number 3, Research Updates and Strategies from COVID-19, has an incredible panel members there with great experience that I have the pleasure to be working with some of them during this COVID-19 fight against COVID-19. And we're going to go with the order of the speakers. They'll have about 20 minutes. Questions and answers will be at the end of the session. My co-facilitator for this session is Dr. Robert Trotter. Hopefully he'll be able to join us. Some of us are having difficulty in joining the Zoom meeting, but he will be facilitating this session. So thank you again to our panel members for joining us today out of your busy schedules. So my first presenter is Paul Brierly. Paul was chosen to serve as the inaugural executive director of the University of Arizona in Yuma's Center of Excellence for Desert Agriculture, which has built into a highly effective research organization focused on usable results and has built a successful public-private partnership. Initiatives, research projects involving industry and academia to maximize agriculture productivity. And he also has been involved with us on COVID-19. His presentation is Yuma County Pilot Project, COVID-19 Community Protection, Early Warning and Response Program. Thank you, Paul, for joining us this morning.
You bet, Amanda. Good morning. I'm trying to share my screen, but it says host disabled participant screen sharing. So I wonder if somebody can enable my screen sharing.
Does it have to be shown by us? So Amy's...
Hang on just one second, I'll get that.
We're going to send a message to as Chris with the telemedicine program, who is hosting our station. So we'll see if we can get my staff get a text message to them to allow you to share the screen. Did you sign up as a panelist this morning, Paul?
Oh, it's working now.
Okay.
Amanda, real quickly, who is the co-facilitator that you mentioned?
There we go.
Let's see. You're probably not seeing it full screen quite yet, huh?
Correct. It's
I got a PowerPoint
there you go.
That I'm looking at.
There, how's that?
Yes.
There we go. Perfect.
Okay. Great. Thank you. Yeah, thank you, Amanda. I appreciate the opportunity to be here. As she mentioned, I run this Yuma Center of Excellence for Desert Agriculture. It's a unique public-private partnership, which was a proactive effort by the agriculture industry here in Yuma County to work with the University of Arizona and basically solve the pressing problems. And of course, when the pandemic came along, that was a pressing problem. So we got involved. Let's see. So first of all, I just want to briefly make sure everybody knows what waste-based epidemiology is, because I'm going to talk about what we did with that process. And basically, this is to sample wastewater, and I'll get into more detail on this, but sampling wastewater to look for the COVID-19, the virus that causes COVID-19, and quantify that and watch for trends and alerts of infections, whether you're doing it in a large community or in a small closed community. But it lets you, it has some advantages that you are sampling everyone. So you're not just getting results from people who have had symptoms and gone to the doctor and had a test, you're sampling everybody. And as the professor, Dr. Pepper, that we work with on this says, poop doesn't lie. So you really know what's going on. And the other advantage is it gives you about a week's notice. In other words, when someone gets infected with the SARS-CoV-2 virus, they begin to shed it in their feces about a week before they would ever show symptoms. So it is an early warning system before people would even know they were sick. So how does it work? First, you define a community that you're going to sample from. Traditionally, this is not a new technology. It's been used in communities, and as you can see on the left side of this slide, you can have a whole city that feeds into a wastewater treatment plant, and you can monitor. They use it to monitor for polio, for opioids, things like that. When COVID came along, then some innovative scientists figured out how to wade through the wastewater and find the virus that causes COVID. So basically, you collect a sample, you filter it, and then you concentrate the virus. You extract the RNA, and you put it through a PCR process to quantify whether you have the SARS-CoV-2 virus in there. And if you do, then you can quantify how much you have. And that gives you obviously levels of infection as well as trends over time. So when you have that capability, like I say, you can define what the community is that you're sampling from. It could be a full municipality, could be a school, could be a dormitory, could be processing facilities, packing houses, factories, things like that. It could be long-term care facilities, any kind of vulnerable population, prisons, military bases, tribal nations. If you can define the community where the sample is coming from, then you can monitor that community. So the first example, and a lot of you may have seen this in the news, at U of A, they had developed this capability there at the West Laboratory, Dr. Ian Pepper. And they were tasked with, so University of Arizona was one of the first universities to announce that they were going to have in-person learning in the fall of 2020. And part of their attempt to make that a safe proposition was to have waste-based epidemiology, wastewater testing at each of the dormitories. And so the students had to test negative for COVID before they moved in. Visitors weren't allowed. They lived in their dormitory, and then the dorms were tested regularly. And I think just a couple days, maybe a couple weeks after they moved in and school started, the waste-based epidemiology testing showed a positive. And you can imagine that created quite a stir, and they had a late night meeting with all the way up through the president of the university. And they decided what they would do is test every student in that dormitory. And so they tested, I think it was 311 students. And from among those clinical tests, they found 2 infected students. They removed them to a special isolation dorm, and the quantity of virus in the wastewater quickly returned back to a negative result. So by doing that, they were able to remove the students who didn't even know they were sick before. And that's another key thing is if you're testing regularly enough, you're going to catch them before they're peak shedding and before they're contagious. And so you pull them out and save contagion. The other point is with a closed community like that, where you know who the people are contributing to the samples, and then you do community or clinical testing, you can quantify the shedding rate of infected individuals, as well as figuring out how many are asymptomatic versus how many are symptomatic. So on that point, I wanted to share this. This is a very busy slide, but the key point is in that kind of closed environment and knowing who the population is and doing the regular clinical testing alongside the waste-based testing, 80% of cases out there in the community are asymptomatic. So that was really key to know that the people who are getting symptoms and knowing that they're sick is only 20% of the cases out there. So let's bring it down to Yuma County. This is a timeline. I'll go into some of these in a little more detail. But back in the summer, we got a donation from Jesus Tovar at T&P Farms in Somerton. And he asked, could we do something that would help put Yuma County safely back to work? You probably all know that we have a very active, large winter vegetable season. And so in the summer, he was looking forward to the fall when we would have a full complement of labor in the fields and in the packing houses, and wanted to see how could we keep that workforce safe. If you remember at that time, some of the backdrop was meat packing plants with workers getting sick and spreading it to their fellow workers, making it very difficult to stay in business. So we did some consultation with the university and looked at all the different options we could do. We talked about a lot of different things. We settled on this waste-based epidemiology, hoping that we could keep the ag workforce safe through this testing, but also that to do it with the early warning aspect of it, we would need to do it in Yuma. So we wanted to set up a lab here in Yuma to do the waste-based testing. I was encouraged by Supervisor Russell McLeod to go to the Yuma County Board of Supervisors for some baseline funding for that. And we were fortunate and appreciative that the Board of Supervisors in August approved funding for us to get the equipment we needed and a couple lab technicians to set up the lab. That turned out to be quite an effort because of, number one, supply chains being disrupted by COVID, plus so many labs being set up for COVID testing and everything. But through heroic efforts of my staff and at the university, we had a fully functional laboratory by November of 2020. So with that, we were able to start doing some testing. And in November, we tested Date Pack, which is a local date packing facility. And we also were testing the dormitories starting in basically in January at AWC. And I'll get a little more detail on that in a minute. After that was started, then we had proposed a project to the State Department of Health Services, and they came through with funding for us to implement a countywide monitoring and response program. And with this, we hired, up to this point, we were handling the science okay, but this whole public health area was new to us. And so we brought on Dr. Bradley Schmitz as a visiting researcher. He's a national expert on waste-based testing and the COVID response. So we were fortunate to bring him on. We expanded the lab capacity so that we could do all the testing that was needed. And we got the cooperation of all the municipalities around Yuma County, along with the public health agency, the schools, the hospital. And we built a steering committee with all of those stakeholders to figure out the best way to do this. Like I say, the science was well established, but the communication and all of that part needed to be developed. So that was a key, and Yuma County really is a model for what we did. And again, I'll get into that a little later. The third major thing that came along was to look at the schools, and Yuma County also funded a pilot project to test schools and see what does that tell us. What can we learn from testing the schools as we tried to transition back to an in-person learning environment. And that actually, shortly after we got the funding, they went completely remote, and so we were just able to do that here at the end of the semester, and we're finishing that up now. And then the last thing is, as the new variants were coming in, Waste-based epidemiology is a great way to monitor for any new variants coming in and seeing whether any of those are breaking through the vaccines. So that's ongoing. So just a couple photos. Like I mentioned, we've built up the lab and the personnel. There's a couple ways to grab samples. One is a grab sample where you just take a collection when you're there. Another is this machine that you see here, which is a composite sampler. And that is put down in a manhole, and it takes small samples like every 30 minutes so that over an 8-hour or 12-hour day, you can have a composite sample of what's gone on all day long. And then our lab, we set up with hoods and everything else. It's a biosafety level 2 laboratory. And like I say, we now have 3 technicians working in there, all right here in Yuma County. And once that lab was in place, it really made it a community resource. So I mentioned DatePack. They are, like I say, a date packing facility. They have 2 shifts of about 100 employees each. They were very enthusiastic to participate with this programming and actually pay for the service to be tested. And what we set up was a schedule of twice a week, going and taking a sample from their wastewater and testing that. And we generally have results back in about 24 hours. We started testing there just before Thanksgiving, and we were getting negative results, so nobody in the workforce was infected. After the Thanksgiving break, and we all know what happens at Thanksgiving, they came back and we got our first positive. And I remember the day well, because it really was kind of our first rodeo with this. And I got the call about 9 in the morning that we had a strong positive. What do we do? You know, they're concerned. What should they do? How are we going to handle this? And so I reached out to Diana Gomez, the director of Yuma County Public Health, and she's been a terrific partner all through this. I was able to reach her, and she was able to reach none other than Amanda Aguirre at the Regional Center for Border Health. And by 2 o'clock that afternoon, we had a mobile testing unit from the Regional Center for Border Health out there in the parking lot, and that was at the time of shift change. So they could test both shifts, test all the employees, clinically test them. And they actually found four asymptomatic infected individuals, and one of them had a spouse working in the facility also. So those 5 people, one of whom was a bus driver, so could have spread this fairly widely, not to mention just the ones working together in the facility. They were all asked to isolate. They were paid and continued receiving their salary, but asked to stay home. And the week after, when we did our testing, it went back to negative. So we believe we averted an outbreak that would have happened, could have shut down the facility, certainly gotten some people sick. So we had a repeat of that later on in February. There was only 1 person that was sick at that time, and that shows how sensitive the testing is. But we've had similar stories with the Arizona Western College dorms, and both plan to continue with this process. So I did want to cover the state project that I mentioned, and this was an early warning and response. I underlined the word response there because the whole point of this project, well, 2 main points, was to do regular monitoring around the county, but to know when there's an outbreak, when there's a large increase in a certain area of the county. And again, rather than having county-wide metrics, we could have it localized by community. But the other thing was to focus responses. So if you're trying to target, where should we have mobile testing? Where should we have, where should we push our communications, public outreach? If you target it where there's a rise in cases coming, then you're going to better utilize those resources. So that was the intent. And and we did it with localized surveillance. You can see the heat map on the right, where we've got the different municipalities around the county. And let's see, go to the next one. So this is just a list. Within Yuma and within the foothills, we were testing at 3 different spots, and in San Luis, 3 different spots, and then Somerton, 1 spot, and Welton, 1 spot. But a key, I mentioned response. So one thing we could do in response is whenever there was an increase somewhere, we could then do more targeted testing. So if there was an increase, say in the foothills, or in San Luis or wherever, we could then target things like prisons or schools or different facilities where there might be, to try to help understand where the increase is coming from. So this is a very busy slide. I don't expect you to read it, but just to show you that we had a process basically from collecting the samples, which the municipalities all did. They agreed to collect the samples and get them to us, running them through, quantifying them, getting the results back to the municipalities, checking with them to see, is there some reason that this particular spot is increasing, maybe doing follow-up testing, and then getting word out if that's appropriate. So I'll just breeze through this, but we do, like I say, we do quantify the level of virus that we find, and we basically put it into these different levels of concern, which is either no response needed, enhanced awareness, we recommend clinical testing, or if it gets to a real high level, recommend staying at home. But again, these recommendations can be taken at more of a local level than a county-wide level. So this is an example of over time what our results shown. This is a logarithmic scale, so each increase of 1 number is actually 100 times the quantity. So it's a big deal when it goes up. And you can see the 2 spots, one in February, one in late March, where we were seeing some pretty big increases and actually did initiate public alerts. So every Tuesday and Friday, after samples collected on Monday and Thursday, we get results out to the municipalities, each municipality individually. We give them the spreadsheet, the results, that graph you just saw, and an interpretation, letting them know, here's what the concentrations are, here's what the trend has been, and if necessary, like you can see at the bottom, we had an alert. We recommended that they coordinate with public health services to see if they want to perform an action as a response. Every week, then, we consolidate that information and share it with the entire steering committee, which, like I say, includes the municipalities and public health and the schools and the hospital. So this is, again, just to give an overview of what's going on in the community, where it's increasing, where it's decreasing, what kind of levels we're finding. So what does that lead to? On those 2 instances I showed, Yuma County put out an alert. The first one because it was in the foothills and that unincorporated area. So Yuma County put the alert out through their communication channels, and then that quickly got into both the regular media and the social media, which generated some interesting responses. We learned, for example, that we shouldn't talk about wastewater testing because people became concerned that COVID was in their water and they were boiling their water. So we needed to change our language, and we now call it sewage testing to make sure that confusion doesn't happen. So I don't want to run past my time. In summary, Yuma County really is a success, and I say that confidently because, like I say, we have a visiting researcher who's a national expert, and really nowhere else in the country that he's aware of is this wastewater testing being utilized by public health officials to decide on targeted response and alerts. In most places, it's just kind of another data point. But us with our steering committee and everybody engaged allows us to do that monitoring, to do that response, to do the public outreach, all based on this early warning of the trends that are happening. And that's really good for resource management, good for the health response. Thank you. So I'll just finish up with next steps. So we are funded through June to do the municipalities. If we can connect with San Luis Rio Colorado, we would love to provide testing for their wastewater also, not all over their city, but to get some feeling for how does that correspond to what's going on here. We're wrapping up the schools testing, which being mindful of time, I won't go into that, but we were testing at schools. We didn't get a lot of response there, but we did get some hits, and they notified the parents and the community that there was at least coronavirus in the school. I mentioned that ag facilities and dormitories is ongoing. We're watching for variants. We're going to also see, we're looking for particular ones, but we also want to see if we can help look for new ones through sequencing of the wastewater. And we intend to be around for probably the next year. Hopefully won't be needed after that, but at least for this purpose. There's other reasons that this kind of lab can be used. But we are open to working with people if there's people that would like to have their facilities monitored and tested. So with that, I appreciate the time, and I'm certainly happy to answer any questions. There's probably not time now, but feel free to reach out to me.
Thank you, Paul. Thank you very much. Can you hear me?
You bet.
Thank you. Thank you for your presentation. It has been a pleasure working with you here in Yuma County.
Thank you,
the
Amanda.
questions and answers,
terrific.
we're getting some questions in the Q&A section in the chat, and we'll go back to them at the end of all the panel's presentation. So our next presenter is a pleasure to introduce Dr. Joshua LaBerre. He's the Executive Director and Professor of the Biodesign Institute at Arizona State University. Dr. LaBerre is one of the nation's foremost investigators in the rapidly expanding field of personalized diagnostic. His efforts focus on the diversity and validation of biomarkers, unique molecular fingerprints of the disease, which can provide early warning for those at risk of major illnesses, including cancer and diabetes. Dr. LaBerre was recruited to the Biodesign Institute at Arizona State University as the first Piper Chair in Personalized Medicine in 2009. Previously, he was founder and director of the Harvard Institute of Proteomics. Welcome, Dr. LaBerre.
Oh, thank you. Now, are my slides sharing properly, or do I have the wrong version of the screen up?
We're okay.
Oh, it looks okay? Okay. Okay, good. Yeah, sometimes different versions, it shows the presenter view and not the main view. Well, listen, thank you for inviting me. I'm just going to give you a little kind of brief summary of some of the stuff that we've been doing at ASU in terms of the response to the COVID, particularly on the clinical testing side, which I gather is the theme here today. I'm just going to start by reminding everybody that that this virus that we've been dealing with for the past year, I like to say it won the virulent virus trifecta because of three characteristics. First of all, its severity. It has a very high morbidity and mortality rate. On average, around 2% of the people who encounter this virus for the first time die from it. That's a pretty high mortality rate. It's around 10 times worse than the flu. And of course, we're only now beginning to understand, for those people who survive the virus, what kinds of post-COVID syndromes they may encounter. And we're encountering all kinds of people who months later are still having symptoms crop up from having been infected, not even people who were in the hospital. The second is that it spreads very quickly. It has an airborne transmission. It spreads through droplets and aerosols. It's extremely contagious, particularly the variants that we're encountering now. Very easy to get this virus if you're not careful. And then the third reason is that it's stealthy. And by that, I mean that this virus spreads to people even before they know they're sick. The peak of infectivity can occur days before symptoms occur. And so people become carriers and transmitters of the virus, and they don't even know that they're doing so. The transmission of this virus is what we call exponential. That means that one person here in the middle can, yeah, this person here can give it to several other people, and each of those people can give it to several other people. And I'm sure all of you have seen these, rapid growth curves where the virus can spread, like crazy. And of course, if we can interrupt that viral transmission by informing people that they're infectious, getting them to isolate themselves until they pass their infectious stage, we can and have saved lives. And I think a key to this whole process, particularly before we had the vaccines, was informing people when they're infected that they're infected so that they can take the appropriate measures and prevent transmission to further individuals. This just reminds us that the chief form of spread here was just simply conversation. When we talk, we produce 2,600 droplets of saliva per second. Just think about that for a second. 1 second, 2,600 droplets. So a conversation involves a lot of spread saliva. Effectively, when we're talking, we are surrounded by a cloud of moisture that comes from us. And if we're near other people, then there's going to be a transmission to those other people. So this is why for a long time that we were recommending 6-foot spacing, and of course why we were encouraging people to wear masks. But again, part of the challenge has been individuals not knowing when they were infected. So around March of last year, our group recognized that there was insufficient available testing for this virus in the state of Arizona, and certainly at Arizona State University, where we had, well over 100,000 souls who we wanted to take care of and make sure that they were adequately tested. So, we began having conversations with the local hospitals in the Maricopa County area to learn that there weren't even enough nasal swabs, let alone available clinical tests. And so, because the technology around developing these tests was already present in my laboratory, and specifically not just the devices, but we actually had the robots that we needed to actually run a lot of tests, we thought we might be able to pivot that technology over to developing tests for SARS-CoV-2. So we worked during late February and March to develop a rapid and accurate qPCR test. That's the gold standard test for doing clinical testing. We managed to get CLIA certification in that month and make sure that we were operating under an FDA cleared test so that we could actually use this test for people. And by the beginning of April, we were running tests in support of local hospitals, in helping Arizona critical infrastructure people and first responders. So initially we started offering these tests to folks in the community that needed to be tested, particularly if they were in jobs that would not allow them to maintain the adequate 6-foot spacing that we would normally expect from people. People, for example, who manage the power grid have to work in very small control rooms where they cannot maintain that spacing. And if any of them were to become ill, that could threaten the power grid. So that's why we started running routine testing for them. By June, we had scaled up our automation to the point where we partnered with the State Department of Health Services to start providing free public testing for COVID-19. And they started funding us. And then we started doing pop-up sites where we were doing clinical testing. And this initially began locally, but very quickly spread throughout all of Arizona. And we have been testing throughout the state since that time. So we've been offering free public testing all over Arizona. Initially, our testing was done, and you'll hear about this in a moment, using the nasopharyngeal swabs, but eventually we expanded that to a much more convenient test. One thing I'll note here is that many of you may remember last summer, a lot of the commercial testing suppliers were having trouble getting the results back quickly. Many times people would get tested but would not find out their results for 7 to 10 days after the test. And of course, that doesn't really help us stop the spread of the virus. What really mattered to stop the spread of the virus was telling people quickly that they were infected and get them isolated before they have a chance to spread it to anyone else. So we routinely maintained our response times to around 30 hours. So, and to this day, our response times are closer to around 24 to 26 hours. And of course, by the time the fall rolled around, we had enough automation in place that we were running 12,000 samples a day. This is just to give you a quick idea of the scale and scope of what had to happen to make this happen. I'm not going to go into great detail here, but just to point out that we had individuals whose only job was to make sure that we could maintain the supplies we needed. We had to order over 1 million tubes to collect samples in. We had to order all kinds of tips for our robots. We had all kinds of plastics that we needed to run our samples. And we had to make sure that we had enough of them that we would never run out when there was a clinical demand for testing. Tamara Duzer helped our relationship management, and she set up all the teams that were traveling around the state to set up the clinical sample collection. We had an automation team in place that ran all the robots to make sure that we could run those samples. We had to develop a database that could collect all the results from all of those tests and deliver them to the individuals who were tested in a private manner, so that the integrity of their private medical record was maintained at all times. And so that's called HIPAA, and we developed a portal that people could log on with their cell phones or their computers so they could get results and keep them private. We worked with contact tracing teams so that when results were positive, we could track them down and make sure people were notified that they might have been exposed to the virus. We had a team just in charge of quality systems management. This is to make sure that everything we did was maintained at a very high level of quality and that would be compliant with all of the regulatory systems that have to be in place for clinical testing. We did have a regulatory clearance team that made sure that all of our documentation was available for both our CLIA certification and for the FDA. And that team to this day is still in touch with the FDA routinely. And then we had a communications team that was specific for getting the word out that we had testing available broadly for the community. So as I mentioned, when all of this started, the method that we used to collect samples was this nasopharyngeal swab sample, which you see illustrated here. If any of you have had that sample, as I have, I'm sorry, it's not a particularly pleasant process. It's not terrible, but it's not pleasant. But more importantly, what we realized was to get those samples from the community was going to be challenging using that approach. And this is what it looked like at one of our typical drive-through centers. These were all volunteer nurses from the ASU's nursing school, set up with, they had to wear all of this PPE to protect themselves, because when you put a stick in someone's nose, they may sneeze on you, they may cough on you. And of course, if they're carrying COVID, then you're now at risk. So they had to be fully protected. And that's why we used cars, in fact. But the flow rate here using this approach was around 25 samples per hour. And knowing how many people in our communities needed to get tested, we quickly realized, even during the month of March and April, that this was not going to be sustainable. And so we quickly started developing, instead of this, a saliva test, which we knew we could collect much more readily from people. It was more, it was easier to collect, and it required less PPE and less nurses. So we developed this saliva test, and by June, we were already we had shifted over completely to saliva testing, all the time maintaining the regulatory with the FDA to make sure that it was legal. The saliva test meant that it was a less invasive test for people, so people didn't have to go through the stick in the nose all the time. It was safer for our testing staff, who did not have to risk getting sneezed upon. We didn't have, we really wanted the nurses to be in the hospitals taking care of people. We didn't want them to have to be standing in parking lots collecting samples. We didn't have to get so much PPE, and we were able to accelerate our testing rate from 25 samples per lane to literally hundreds of samples per hour. So we were able to collect huge numbers of samples and get much more ready testing done. Since then, our testing crew has now become both nationally and internationally recognized. We have been sending our protocols all over the country and even over the world to teach other places how to do what we did. So we shared all of our protocols with them. At the same time, we've tested now over 830,000 people as part of this testing program. And many of them have since then volunteered to participate in research, clinical research related to COVID-19. I think a big question that all of us want to understand better is going to be related to these post-COVID symptoms, because A number of people are now complaining of that, and we want to understand that better and figure out ways to fix that. Our team, in conjunction with all the testing, developed a web page for tracking what's happening in the state of Arizona in terms of COVID-19. So we have this critical COVID-19 trends page on ASU's server. It tracked how many cases have occurred in the state of Arizona. It tracked the case rates. It tracked the rate of change of the cases. And now we're tracking vaccines and vaccine successes. And so we've been posting that daily ever since. And many thousands of people have been using those sites to track the response. So this is just a quick summary of what we've done. As I mentioned, over 830,000 tests. Our turnaround time is less than 30 hours. When we were at our peak, we were running over 100 testing sites per week. I know we had sites in Yuma, but we also had them in every county in Arizona. We've been helping hospitals. We've been helping critical infrastructure organizations. We worked with some of the tribes. And of course, we even did all the testing for state employees. So when the Department of Health Services got their testing, we were the ones who did their testing for them. So we've been doing testing kind of all over the place. We have been paying a lot of attention to the emerging variants. I'm sure a lot of you are familiar with this issue. As many of you know, the now dominant strain in Arizona is this B117 strain, or the UK variant, which is much more transmissible than the original variant that we had here in the state. It's also somewhat more deadly, but it appears to be the dominant strain here. ASU was the first to identify a new strain of SARS-CoV-2. It's called the B.1.2.243.1. It's not a very dominant strain, only a handful of people, but it's unique to Arizona. So we reported that. And then we have identified very few number of cases of the India variant, not particularly dominant in Arizona. Right now in the state, the UK variant is the dominant one. It turns out that the test that we use at ASU specifically gives a unique pattern, 2 genes positive, 1 gene negative, that is characteristic of the UK variant. And you can see this plot, which is on our webpage, showing how quickly the 117 strain became dominant in Arizona. Starting at the beginning of March here, you can see down here, we had a few cases. And now in our most recent testing, all of the cases we looked at had that pattern. So typically on any given day, it's around 60 to 70% of the cases have that particular variant. We also have an active program to do sequencing of other variants, and we're part of the overall Genomics Union that includes the University of Arizona and the Northern Arizona University, as well as ASU, and all 3 universities are working together to kind of track all the variants in the state of Arizona. To give you some sense of the update on the state, on the university, our university population, which was tested regularly by our own testing system, consistently maintained low incidence of infection. So even when the state of Arizona had 14% positivity, typically we were under 2% for our faculty and under 3% for our students who are living on campus. So we've really been very vigilant about watching this. I'm going to wrap up real quickly here. I just want to mention something that we're all familiar with, which is the vaccines. I think we're all thrilled that they have been as successful as they've been. As you know, there are 2 mRNA vaccines now available since the early part, since the end of last year, really. And now also a non-replicating viral vector vaccine. All 3 of these vaccines were tested on populations with broad demographics. And now over 275 million doses of vaccine have been given in the United States alone, over 1 billion, I believe, in the world. If you've had these vaccines, they practically eliminate any risk of severe COVID disease. The number of people who've had severe COVID disease after a vaccine is vanishingly low. They are very effective at preventing severe outcomes. They also have almost no major side effects. There are a few people who've had some significant side effects, but those numbers are, again, extremely low, although there are some minor side effects. So they have been remarkably effective, and I would encourage anyone who hasn't been vaccinated to go get vaccinated. the risk of COVID-19 for those who have not been vaccinated is still there. There is a 1 in 5 chance if you are unprotected and you get exposed to the virus that you will have a severe outcome. That's like having playing Russian roulette with 5 chambers and 1 bullet of having a severe outcome. So much better to get vaccinated. That's my advice. These are just, I want to just thank these are the people in the lab. Often, many of them are students and young people who volunteered their time to run these tests for the community. And here you see a number of them who participated in that. And here are some of them at work. And I will stop there, and I know we'll have questions later. So that's all I have to say. Thank you very much.
Thank you, Dr. LeBaire. Incredible study and results. I know that with the city of San Luis and in collaboration with the county health department, we did some testing in the border with farm workers as they were crossing the border. So thank you for that leadership and your work that you're doing in the state of Arizona. Appreciate it. Thank you.
Yeah.
Our next presenter is Samantha Sabo. Dr. Sabo is an associate professor at the Center for Health Equity Research at NAU. And for more than a decade, Dr. Sabo has examined the social and political context of chronic disease among immigrants and migrating communities of the U.S.-Mexico borderlands and indigenous people of the region, with a primary focus on the role and impact of community health workers, interventions, and advocacy on the social determinants of health of vulnerable populations. It is my pleasure to introduce Dr. Sabo. Thank you, Samantha.
Thank you, Amanda. Buenos dias. Good morning, everyone. I'm happy to be here, and it's just an honor to be listening to Dr. LeBaire and Paul and their excellent, important work. I've had several COVID tests from ASU, so it's awesome to finally put the face to the magic. I am here to talk to you about also a collaborative effort across the university systems here in Arizona. This is a National Institutes of Health funded project called Community Engagement Research Alliance. We call it SEAL for short, against COVID-19 in disproportionately affected communities. And so I look forward to sharing the work we've been doing collaboratively, and we'll switch gears a little bit to more of the qualitative or the human stories related to COVID-19 and the rollout of the vaccine. I just want to acknowledge the land that Northern Arizona occupies. We are at the base of the San Francisco Peaks, and these are homelands sacred to Native Americans throughout the region. And I just want to honor the past, present, and future generations who have lived here for millennia. It is warm here, so we look forward to people coming, and it does look a little bit like this. Our wildflowers are still blooming. And the wind is still blowing. So again, I'm going to talk to you a little bit about this National SEAL Alliance, really to engage, conduct community engaged research to address the misinformation and mistrust that had been built up over several months during the pandemic. So, and to promote and facilitate inclusion of diverse racial ethnic populations in clinical trials, that were also being launched very rapidly, specifically with the vaccine. So the National SEAL Alliance, how it works is SEAL research teams focus in 2 primary areas, as I mentioned, to support and expand community outreach as it relates to COVID, prevention of COVID, and establish communication networks through national networks. So Arizona was one of 11 hardest hit states that were prioritized for this funding. These are 1-year grants of $1 million with a new supplement that came just a month ago to supplement that work of another $1 million in this state. We were funded in September 2020 and rapidly stood up a partnership across the 3 universities and Mayo Clinic to begin our work together. So as I mentioned, this is a broad-based partnership. We focus in partnership with members and leaders of the African American, Latinx, and American Indian communities to really conduct that necessary qualitative and quantitative work to really understand the awareness, experiences, concerns, attitudes, needs, and misconceptions regarding COVID-19 testing, prevention, research participation, and vaccine uptake. So if you remember, COVID-19, we're always behind the 8 ball. As Dr. LeBaire mentioned, you know, we remember a time when there was not enough testing. We remember a time when the vaccines absolutely did not exist. We remember those times that you couldn't get the vaccine once it was rolled out. And so this is always interesting to present information about what was going on when only it was 3 or 4 weeks ago or 2 months ago. So oftentimes we are really trying to keep up with this virus and how people feel about it and understand it and experience it. And so the data that I'll present to you was from January and February, which has completely changed. And so I want to acknowledge that as we try to keep up pace with COVID-19. So our role really is to try and understand. At the time, NIH was very concerned with the level of misinformation and mistrust that had existed due to a myriad of issues going on nationally and in our states. And so we were trying to get ahead of that to be able to produce messages and materials and educational resources that were evidence-based, culturally salient, and made sense to people so they could take decisions about the vaccine and the ways that they could protect themselves. And then we're researchers, so we like to evaluate and see if stuff works. So our phase 1 was really to collaborate, assess, and create. So in partnership with ASU and NAU and ASU really took on the qualitative side of engaging Arizona households, as well as community health workers, which I'll talk about in a minute, in focus group conversations about COVID-19. And those conversations are continual, so we stagger them over time so we can keep up with people's changing attitudes and feelings and beliefs. And we try to keep moving and to be able to develop messages and education materials and trainings to be able to meet that demand. So our phase 2 is really on the collaborate to educate and evaluate. We have a statewide task force that's focused primarily in Maricopa County, but we do have representation of other parts of Arizona. NAU obviously is trying to represent Northern Arizona rural. We also are charged with tribal engagement, and so we have several tribal partners that we work with. We partner, NAU specifically partners with the Arizona Community Health Worker Association. And if anybody doesn't know what a CHW or a community health worker or a promotora de salud is, then you need to ask some good questions, because these are the incredible men and women that serve as the link, bridge, glue between people and systems. And so all of this work that we've been able to listen to today oftentimes gets translated and connected to individuals through community health workers. So CHWs represent a workforce recognized by the Bureau of Labor. There are approximately 1,500 CHWs in the state of Arizona. 30% of those CHWs are tribally employed. They are called community health representatives. And these are the people that are on the front lines talking to people, convincing them that COVID is real, convincing them that a vaccine is safe, convincing them that they should go and get that preventative screening and take care of their diabetes during the pandemic, to not be afraid to go to their primary care visits. These are those men and women that we love. And visually, we have them in the center of the universe. You know, they are the ones that are connecting between all of these various systems. And so we partner with the statewide professional association, which has a training center, a CHW training center, to basically take all that qualitative work, analyze it as quick as we can, and pump it back into an opportunity to develop education and training. So that's kind of what ASU or NAU and as shall do, the University of Arizona, they have a really awesome system developed by several folks there at the beginning of COVID-19, a text messaging system that can both collect information and pump or push out messages. So we share our qualitative work, we develop messages, and then those messages are weekly delivered to residents of Arizona. And then ASU, apart from the qualitative work that they are doing with households, is also working with the social media and development of animations or opportunities for video and animations to communicate some of these messages and some of these prevention messages. So it's really a nice partnership. None of us knew each other before this started. So we were all pushed together and we've rallied, and it's just fantastic to be able to be part of this incredible group of people and team. So today I'm going to really focus on the focus group results, and I'm going to probably go a little quickly just to make sure you know what we're up to and how that is going. These are specific because we're talking about border health, we're talking about the social determinants of the region. I'm only going to speak to you about the results from our focus groups with community health workers who consider themselves promotoras, serving Latinx, immigrant, Spanish-speaking community members in the border region, as well in the Phoenix area. And so that's who I'll be talking about. But please know that we've conducted focus groups to be representative of the workforce and also disproportionately impacted community members. And I will share a little bit about the brief survey topics that we are surveying through that text messaging system, as well as the CHWs that completed it. So community health workers that participated in our focus groups, we just want you to be aware that they were predominantly Hispanic, Latino, predominantly women. This is very reflective of the workforce in terms of their household income and their education levels, as well as their healthcare coverage. So this is an important workforce, but I want you to understand that this is also a workforce that is representative of vulnerable populations, oftentimes going with low wage, going without health insurance, and there's opportunities to advocate on behalf of this workforce. So in terms of CHW prevention activities, you would assume that they are engaged, highly engaged in prevention activities. This was in January and February. So everyone was, 60% were trying to maintain those physical distances, high mask usage, and hand washing activities. And these are some of the questions that we ask our community-wide residents to kind of monitor over time how people are engaging in prevention activities, because it shifts as our two presenters were sharing with us. This is again just a reminder that this workforce is so incredible, but also face many of the challenges that communities hardest hit by COVID have also faced. 30% stated getting healthcare they need was a minor or a major challenge, which shouldn't be the case for these frontline workers. And getting medicine was a minor challenge, while getting to where they needed to go was also a minor challenge for about 20% of the population. So just a little plug for supporting this workforce. If you employ them, if you are an advocate or an ally for the CHWs, really important to make sure they have all the tools that they need and that they themselves are healthy to be able to serve the clients that are so important to our efforts, all of our collective efforts. CHWs are highly likely to get the vaccine, 80%. And many had been, almost 80% had been tested for COVID at the time of the participation. And again, high percentage of mask use, all or oftentimes. We talked to CHWs as well as the larger Arizona population about trusted sources of information, and over and over and over, both in CHWs as well as the larger population, the doctor and the healthcare provider are the most trusted sources of information. So almost 80% of CHW said that, and that's very consistent with our data statewide. And this was in February. So if you remember, we had a high percentage of doctors, of licensed healthcare providers that were hesitant about the vaccine. I think in Arizona it was almost 60%. And so really these data help us to understand where we need to support messages, because if people are trusting their healthcare provider, but the healthcare provider is on the fence, we've got a serious recipe for disaster. The one cool thing that we did find in social media, y'all know, you know, almost half of CHWs just don't trust their contacts on social media. Social media kept coming up over and over as a major source of misinformation. And this was consistent. This is pretty consistent across. So although people don't trust their contacts, they still view them. And so that's a kind of a funky space to address in terms of COVID-19 misinformation and the spread of that misinformation. So reasons to get the vaccine is always around keeping my family safe and keeping my community safe. And these data are consistent across our surveys across the state. These are helpful to know how to message. So we have developed messages that are very family, very collective, very community oriented. This is not an individual thing. This is something that I'm doing this for everyone. And so we need to have those consistent messages across our populations to be able to support folks to say, yeah, I'm doing this. This is beyond me. This is about gathering. This is about coming together for birthday parties. This is about protecting my family members and my elders. And so those are the types of messages that we're working on to develop. Issues around, most people said that, most CHW said they were going to get the vaccine, but if they didn't, these are some of the responses that we collect across the state. And so just thinking about side effects, there is some hesitancy around the side effects and not knowing how the vaccine works. And this is also very helpful for us to develop training for CHWs. So now I'm going to kind of switch to tell you a little bit about what CHWs are hearing in their communities from their clients. So we talk to them about what are folks saying to you? How are people feeling? And remember, this is in January and February. So we were still in phase B, I think. We were still in this space where we didn't have widespread distribution of vaccines across all population groups. And some of the themes that were already coming out were these issues that you all know as providers, as researchers, as community agencies, is the availability, technology, the language, and the literacy levels of the information that were coming out about the vaccines were extremely high, confusing, convoluted. Transportation was a major factor for folks, given that at this time there were no pop-up sites. Everything was in these mass vaccination centers, which required a car, which required gas, which required you to take time off work, find a place for your kids or your elders that you're caring for. Immigration was a massive issue as well, meaning that no one understood where this information was going that you had to get online, right? So if you remember, the technology piece is about, at the beginning, you had to have a smartphone, a computer, you had to be connected to the internet, and you had to enter a lot of information into that system to be able to get an appointment. Those barriers have since gone away. Our county health departments have incredibly overcome a lot of these issues, making it just eliminating these structural barriers, frankly, making things pop up, making things show up on the day of, not requiring any type of use of technology to be able to make an appointment, which is awesome. And so some of the social and behavioral themes were really around uncertainty, fear, that misinformation, and just lack of information. Remember, in February, January, March, we didn't have a big rollout of a communication campaign at all about what was in that vaccine. How did that vaccine get developed? Why did it go so fast? And these are the types of questions that people had. They wanted to make informed decisions, but they didn't have the information, or the information that was available was high level, not translated, and it needed to be put into more usable form. Mental health was also something that was very much weighing on people. It still is. The level of loss of life, loss of job, loss of home, loss of place is paramount. And it's something that we all need to really pivot towards as we're moving away from vaccination hesitancy or confidence into really dealing with the trauma that has been experienced by communities. The next is around hesitancy. And so we've since switched this to confidence, really, related to how people feel about the vaccine. This was January, February, and into March. Many folks, and this is, remember, we're talking about predominantly Latinx, immigrant, Spanish-speaking family members. There was a lot of braving the storm kind of ideas around, well, I've never been vaccinated before, so why should I do it now? A lot of people were waiting for later versions. Remember, at this time, the variants were coming, so people were getting confused. Well, does Moderna work for this variant? Does Pfizer work for this other variant? So that was also a communications nightmare, frankly, because people were saying, no, I'm going to wait. I'm not going to get the vaccine because these variants are coming and they don't know if this works for that. So that was really hard. Also, the severity of the virus just wasn't real to a lot of people, even though they had death in their family. There was a very big cognitive disconnect going on for several family members who had lots of morbidity and mortality in their families, but still just didn't believe the severity was as real as it is. And then the scientific misinformation was just abound. All of you can remember the asymptomology issue of if you don't have symptoms, you can't spread it. Really that idea of unknown about if you had an infection before, are you immune? So, well, I've had COVID, I don't need to get the vaccine. So there was those kinds of issues too. So really having to clear up these things in plain language. Hesitancy themes as well that we've addressed through training is vaccines may be risky. That was a big theme at the time. They were developed too fast. They're going to make you sick. They're going to make you crazy and change the way that you are. There were lots of rumors throwing around that they were causing seizures and coma and infertility, that they were going to change your blood and change your DNA. And so that was an issue. In the more Catholic community, there was elements of not understanding what mRNA was and that there was fetal tissue involved in the production of the vaccine. And so that was an issue as well. And then there was real structural issues and very real contemporary traumas around social control and injustice. Oh, good, I'm back. I froze. That COVID-19 was human-made, that vaccines were a way to selectively kill people or control them, and this was predominantly people of color, that this was a way to access DNA and inserting microchips and tracking individuals. And there was an element of that the elite, if you remember, at the time, non-Hispanic whites were getting vaccinated at tremendously high rates as compared to folks that were experiencing the burden of disease, that there was this idea that the elite is going to get something effective, meaning elite white, and that the rest of us, meaning people of color, are going to get some unknown substance. So there was some real deep fear. And I want to just leave you there because I know I'm ending. I wanted to remind you that if you are interested in our text messaging system, which you don't get a lot of texts, it's 1 week, and there's little surveys that take you 2 or 3 minutes. And this is this way that we're monitoring attitudes, beliefs, and feelings about COVID-19 over time. This is our little flyer that we have, and we can send it to you all. If you are interested in training, we've taken all of these messages and we have worked with ASCHOW, and ASCHOW has made these incredible trainings for the CHW workforce. They've trained about 15% of the workforce in Arizona. So they're conducting trainings every month. They will do trainings in your agency. And then we have a slew of materials that supports CHWs to be able to address all of those topics that I just brought up. We also have our report. If you want to read in depth what I just glossed over. We have an awesome report developed by our research team with messages that you can pick up and use. This is for you, and we'll make sure that we send it out through this network, and it covers vaccine and COVID-19 topics such as these listed below. And again, I just want to recognize the research team that I get to work with, who are incredible and amazing and produce all of this information in really rapid ways. And I thank you all for listening. So thank you very much.
Thank you, Dr. Savo. Thank you for that presentation. As you know, we work very closely with our promotores de salud here in Yuma. We have a cadre of 40 people that work not only with COVID-19, but they're addressing behavioral health issues there as a result of the impact of COVID-19. So thank you for that wonderful presentation. Our next presenter, our panel, is Dr. David Engel-Taylor. He's an associate professor and the director of TGen North, the infection disease arm of the nonprofit Translational Genomics Research Institute. He currently oversees the TGen North Clinical Laboratory that was stood up in March 2020 to specifically provide COVID-19 testing, and has provided tests for tens of thousands of Arizonans and has sequenced over 15,000 strains of coronavirus. Dr. Engel-Taylor, David was previously the Arizona State epidemiologist and a biologist for CDC, and they has worked in federal, state, and local government, and has started for for-profit and nonprofit businesses. Dave sits in a number of local and national boards, and recently has led the establishment of Flagstaff, Arizona, as America's first STEM city, which I'm very jealous of that. Should have been Yuma. But anyway, Flagstaff is okay. Dr. Trotter is there, so I'm sure they were happy at NAU to have him in Flagstaff. Thank you, Dave, for joining us today.
Thank you, Amanda. It's fantastic to be here. Thank you for the invitation, and to the organizers of this great session and the overall conference today. I'll go ahead and share slides, and I'm sure you'll let me know if there's any issues. And for those of you who I don't know, yeah, my background has been in public health for almost 30 years. And at TGen, we do a lot of public health work. We actually are actively engaged with state, county, tribal, other local health, as well as CDC and international health. And we respond to disease outbreaks all the time. We help conduct disease surveillance. So we were able to jump in very quickly on COVID and use some of this next generation technology. And I'll describe some of that. I'll describe a little bit of what TGen did, and then more the state of things with the genomics and the variant tracking in Arizona. And thanks to Dr. LeBaire for setting up some of this as well. At TGen, we've been around now since 2002 in Arizona. The screen on the left is us down in Phoenix, and that's mostly focused on the human genome. The screen on the right, that is our shop in Flagstaff, Arizona, where we focus on pathogens and microbiomes. And so this is where most of the COVID-19 response activity has taken place, at least with TGen. And so since actually going back to January of last year, TGen North has really been at that forefront of response in Arizona. We developed actually the first test in Arizona, first PCR test outside of the state lab, which used the CDC test, and developed that back in January, just on the outset that, or just in case this became something bad, and it obviously did. We had a multi-layer strategy. So we had this PCR diagnostic test, like Josh LeBaire says, is the gold standard. After they stood up the saliva testing, which was so fantastic, we did that as well. We set ours up a bit differently, so we weren't using anybody else's commercial assay or CDC's assay. So we were independent of supply chains, and we never had to slow down or pause because of supply chain issues. We have antibody testing really to measure past infection or vaccine status, and we also include dried blood spots. I'll show that in a second. And then viral sequencing has been a big part of what we've been doing since really day one, even that very first case in Arizona. and then using genomics to help solve outbreaks, what we call genomic epidemiology. My last slide on the testing side of things, where we could not be the behemoth that ASU is and provide all that value of testing hundreds of thousands of Arizona, what we can do is be smaller and agile and really focus on making impact with the groups that might need us the most. Our average turnaround time has been less than 12 hours for really the past 8-9 months. We added saliva and dried blood spots so we could have that easy self-collection, so you don't need to use doctors and nurses, as Dr. LeBaire mentioned. But really most important to us was focusing on the underserved communities, focusing on tribes, nursing homes, shelters, corrections. This has been this has been where places that didn't normally have great access to testing, we were able to actively engage with them right away and provide tests as others were standing up very large testing operations. And as I mentioned, working with tribes and border health entities throughout Arizona, which has been a great honor to us. So let me now move on to the genomic side. I promise I won't get overly sciencey on this, but just the basics enough to understand what it is that we're doing. So let's talk a little bit about the virus. The virus, as we all know, is a coronavirus. We used to call it the novel coronavirus. And like all coronaviruses, it has this particular feature of having these spikes, kind of this crown of spikes, the corona on the virus, if you will. And pretty much all coronaviruses, and there's a very large number of them, are found in animals, and the ones that humans get are zoonotic, means that they come out of animals and get into humans. This particular one is likely of bat origin. In fact, we know at some point it was of bat origin before it got to humans somehow. This family of viruses in coronavirus, what we call beta coronaviruses, also includes the SARS virus that we remember from 2002, 2003, MERS virus, or Middle Eastern Respiratory Syndrome virus, which still causes cases, comes out of camels, but actually probably out of bats first before it got to camels and then to humans. Doesn't spread very easily in humans, but very, very deadly. And then two other coronaviruses in this same family that are the ones that cause the common cold. We see these, we generate an immune response to them that probably lasts about 18 months, maybe a little bit longer before it wanes, and then we can get exposed to that particular type of coronavirus again. That might be what we actually see with this SARS-CoV-2 as well into the future. So when we talk about genomics, a lot of times we talk about these family trees. We understand the RNA, the genetic material, look for all the mutations, and then we can determine who is most closely related to who. We use some pretty advanced statistics to do this, and then we develop a family tree. It's called a phylogenetic tree, but it's really by looking at the branching, we can see which species or strains of virus are more closely related. And when we look in this beta coronavirus family tree, here's that SARS virus, the SARS-CoV-2 virus, excuse me. This is the initial strains that actually came out of 2019, early 2020. We could see that it was most closely related to other SARS-like bat coronaviruses. And this is why we know this is a SARS-like bat coronavirus that actually fits in with a large number of other very similar viruses that come out of bats, including the original SARS-CoV virus, or SARS from 2002, which is up here. These also came out of bats. So this is a common source for these types of viruses. I mentioned some of the other ones that are in this family tree. There's the MERS virus down here, and then the other two human coronaviruses towards the bottom. If you can see that, those likely may have actually originated with rodents as well, because they're closely related to some rodent coronaviruses. And then there are other coronaviruses out there as well. So it's a fairly complex family tree, but what we want to do is focus on the actual SARS-CoV-2 tree so we could do genomic tracking. And so here's, we build these trees. Everybody around the world is building these trees to understand this virus, what I kind of call the ancestry.com of COVID. And by doing this, we can track where the virus is coming from, where outbreaks are, how quickly outbreaks are expanding in new regions. And then we can also identify these new mutations, these new variants that pop up, and try to understand their importance by seeing what it might do to the protein structure of the virus. And I'll point this out in a second. And so in Arizona, we've now sequenced over 19,000 total virus genomes. That's primarily at TGen, but many other places in Arizona are helping out, such as the universities, as Dr. LeBaire mentioned. So let's talk a bit about the variants and the mutations themselves. So over here on the left-hand side, we see this cartoon of the virus in the middle here, and it's got these spikes that stick out from the virus, right? And then on the outside of this is actually just a representation of the genome, looking at the different genes that are actually occur within the genome of the virus. And so what can happen then is mutations can occur in these genes that might change the virus a little bit. And in this one gene we see here in red, that's the spike protein gene. And that's really important because that's what's on the outside of this virus. And that's where the virus interacts with the outside world. And importantly here, interacts with human cells. So changes within that can actually cause changes in the spike protein. And here's a picture, if you were to look down on top of one of these spikes, so this is looking on top of the spike, a mutation that some of these that we've heard of, like the UK variant has this 501Y mutation, and that causes a little change right here in the spike protein. And that change could be really important because where the spike protein interacts with the human cell, a receptor on the human cell, if you get a little change in that one area, it could actually, maybe it makes the virus not actually attached to the human cell, but maybe it makes that locking key fit so much better. And in many of these mutations we're following, it does, and it allows the virus to actually attach to the cell, get into the cell faster, replicate faster, and actually cause faster transmission. So one little mutation can have a really big impact on how the virus acts, and that's why we have these variants of concern. I'm showing here some scenes from the Arizona's COVID-19 sequencing dashboard, and there's the link, and I'll put that in the chat box afterwards. And you can check this out live. It's updated every day and includes sequences for all of Arizona coming from all different partners, including TGen and ASU and the Arizona State Public Health Lab, CDC, U of A, and some other places as well that are providing sequences. And then we're tracking these different variants that we've all heard about in the news, the UK variant, really known as B117, or the variants out of South Africa, California, Brazil. We've heard about all of these. And here we're kind of counting up the numbers and seeing these variants in Arizona as they continue to grow. But what might be more important is actually to look at them in proportion with all the different strains that are being sequenced. And so this is December through April, actually April and May are lumped together. And we could see the B117 is in this bluish color, just first popped up in January and then really growing February, March, April and May. It is now 60% or more, as Dr. LeBaire was talking about, in Arizona. So it's become the dominant strain. This is because this strain is very, what we would say, fit. It's easily transmitted. It's essentially a healthy strain that outcompetes the others to find the next susceptible person to infect. And that's why it's winning kind of this evolutionary race right now to be the surviving lineage as we get to the end of this pandemic. But there are some other ones that are out there. The California variants were very important in Arizona throughout much of the beginning of this year. And those are starting to shrink in number and in proportion as this B117 or the UK variant has become dominant. We do see some growing here at the bottom, this red. This is the P1 variant. This is the one that's came out of Brazil, has some ability to evade some antibodies. Vaccines still work for it, so it's not evading our vaccines yet. But it's an important one, not dominating, but it's actually growing a little bit in Arizona. And so we're just tracking all of these variants. There's other links within here that you can look at and explore. And one of the things is that these variants are not the same across the state. So if we look at all the different variants, we could see where they dominate. The B117 completely dominant in Maricopa County, and has popped up although in many other regions around the state. The California variant, on the other hand, especially during the first several months, was really well seeded throughout the state. And that's likely because there were many, many introductions into Arizona from California. And so it really spread around very easily. There's fewer introductions of the UK variant in Arizona, but it transmits and causes many more outbreaks. And then there's this other lineage we didn't talk much about. It's called B11519. Is a US-Mexico variant and is actually very important in Mexico. And we can see it in Arizona. We've only seen it in the southern half of the state. And so likely has something to do with the obviously the location towards the border and where strains are coming from. One other one I want to point out, and this is partially because we've worked with Amanda's group to find the very first Brazilian strains in Arizona. This was going back into very early March, and this had to do with asylum seekers that were in detention that had come from Brazil, and we were able to show that they were positive for SARS-CoV-2, and it turned out to be these Brazilian variants. And this happened a few times, but now if we look, we have all these cases here in red are all the Brazilian variants in Arizona. And just by understanding this kind of a family tree, we know that it's been introduced at least 20 times in Arizona. So there's many different routes for this to come in. A lot of that's probably coming in from the Mexico side, which is having a real problem with this particular variant right now, but also just from places that are other parts of the US and certainly from Central and South America. So this is becoming important. I don't think it's going to overtake the importance of the B117 or that UK variant. This is just to show in the US, pretty much in this orange or peach color, that's the B117, essentially every couple of weeks. And we can see it is certainly the most important variant in the US as well. That's why I think this is going to win this survival of the fittest race. A couple of things I want to quickly point out. We actually use genomics much more than just tracking and counting variants. We also use it for epidemiology to track and understand outbreaks in Arizona. And I'm just going to show you a couple images from one of the tribes in Arizona that had just devastating outbreak in a brand new Arizona strain. It started in Arizona and really spread, became the only these two strains to show up within this tribal community during several months of last year. And what we wanted to do was actually work with the on-ground epidemiologists to tie the phylogenetics or that family tree of the virus to the information coming from the epi interviews, and then try to understand really what is the directionality, where was the actual source and causes of these, which strains actually seem to be spreading faster. And so we did that. I'm not going to go into too much into details here. On the left-hand side is really more the full family tree of one of those two strains in this tribal community. And if I zoom in on this, we can see the very first cases up here in the top on the right-hand side. The very first cases showed up just, I think, like March 29th in this community of last year. And then it quickly spread. This was an individual that spread to coworkers, went home, spread it to everybody in the household. Those coworkers that were infected spread it to almost everybody in their household. There was so much concern, they started sending kids to other households so that those kids would not get infected, but they were already infected and those kids ended up spreading it to those households. And quickly, we were seeing 80, 90 to 100% attack rates throughout this community with these strains. And we could track it and show that phylogenetically, it really matched up with the epidemiology. And then we did that with other clusters. And then we could use the data to actually find what is the common source between the clusters when that wasn't obvious from doing patient interviews. So there's a lot of power behind using genomics. We've done other outbreaks in Arizona, developmentally disabled adult group home and a really sad outbreak that occurred among about 12 homes within this facility, but we're able to carefully and show how it was actually movement of staff between these homes that ended up causing this outbreak. And then we did all the sequencing and outbreak for Major League Baseball last year as well, which was really more of a fun diversion. There were no deaths associated, thankfully, with that, but we could use the tools for that. So really, I want to wrap up with, we are now able, especially with this particular pandemic, to use all of this technology to gain pathogen intelligence for both clinical medicine and for public health. We really need to be visualizing and moving towards the thought of not just testing every case, but sequencing every case for critical pathogens. We could absolutely do this for precision medicine and precision public health. We want to democratize this technology. We're working on creating the 24-hour, $25 genome so that really can be done really by anyone almost anywhere that has these capabilities. We want to democratize the data. This complexities of this genomics really scares off a lot of places from actually using it. We're trying to make it automated and make easy visualizations. You've seen some of that. And also then use this to investigate this data, to investigate the importance of these new mutations and see if they're causing disease differences. And I'm not just talking about COVID, I'm talking about now moving forward with all of our critical pathogens. We're building future capacity, training local laboratorians and epidemiologists how to use these systems and these data. And then for us, one of the big things is prioritizing bringing these advances to the native peoples of the Southwest, not to have this kind of trickle down technology effect that we've seen for so many decades. We can actually be on the ground and using these technologies today. Got to point out, tons of people have supported TGen. We're a nonprofit. We don't have a direct state budget we're not a commercial lab either. So we have relied on the great work of foundations and family foundations and others, including the Arizona Department of Health Services and CDC during all of these many months. And with that, a picture of a wall in our building in our ethos, which has allowed us to stand up and do this work. So I'll turn it back over to you, Amanda.
Thank you, David. Incredible work. And we look forward and continue and working with you and sending you more of our samples. Just yesterday, we had 3 positive families that I believe they're from Ecuador. So we'll continue sending the testing for the migrant refugees that right now we're working with Homeland Security and Border Patrol to test before they're being released into our community. So thank you for all your work. So we get to the question and answer part. Dr. Robert Trotter, he's co-facilitated my session. I know we had a few questions that I've seen in the chat. Some of them were answered, but Bob, I think the first one, I'm not sure it got answered. If we go up to the.
Yeah, I'm going back. One of the questions for Dr. LeBaire is it possible to cooperate on testing and sequencing of specific populations? And they're mainly thinking of correctional facilities outbreak.
Yeah, no, I've already interacted a little bit with Mariana, I believe, who asked that question. So we were doing a lot of sequencing last summer at the correction facilities. I know that we were the chief supplier for them for a while, in part because saliva collection is so non-invasive. I don't know how much we're still doing that. We're always open to collaboration. So if there's a possibility there, we'd be happy to work with them. And I also mentioned that we've got a nice little conduit now within our building. So the samples that we use to test for COVID-19 can also be sequenced. So, and we have a professor in our group that can do that. So if that's something of interest, we're happy to interact on that.
And Bob, this is Paul Brierley. I just wanted to mention also that prisons are a good target for wastewater-based sampling. And if anybody's interested in that, we are doing that as one of the targeted responses in one of the communities here. So I'm open to that also. And
I think we want to open it up to the rest of the panel in terms of where are there opportunities for collaboration, for community engagement.
Well, maybe I'll finish up then. My comment that, you know, as I said in my presentation, really the sweet spot that we found for being able to react and have a good response to the wastewater-based testing is a facility where you have a known population. So a factory where the same workforce is there every day, a dormitory where people live, a prison where people stay, because then you can kind of do a positive negative. If you find that the virus is there, then you can bring in clinical testing and really figure out who has it so that you can isolate them. So we're open to any of those type of facilities, talking to them about testing. All it requires is that the plumbing is set up right such that we can test, so that we can pull samples from that defined community.
And David, you might want to talk about kind of special outreach or special collaborative arrangements.
Sure, happy to. Thanks, Bob, and great to see you, by the way.
You too.
So a couple of things. One, you know, as we kind of move towards this end phase of the pandemic and in the post-pandemic testing and monitoring, what we're seeing is some of our partners are still a large number of the tribes that we work with, multiple correctional facilities. So certainly that's going to be important. And you know, and I know, and I've interacted, we still do testing for some inpatient psychiatric centers, and that essentially work with a lot of individuals that may end up on the street or in shelters. And so there's these at-risk populations that will continue to be at risk because we have lower uptake of vaccine in many cases, and more high risky behaviors. Oftentimes people either cram together or maybe, you know, and maybe haven't been vaccinated. And so that's where we're going to continue to see spread. So we still have to have really good resources for these at risk as we see the state overall numbers drop to, you know, very low levels, and people are going to start feeling comfortable. We're still going to have these pockets. And so it's really important for us, all of us that provide these services, to continue to reach out and know that this is still going to be valuable. The second part, though, I want to also mention is we should be thinking about, and what we're working towards is the post-pandemic and beyond COVID. These are, we've been able to show we can really bring these technologies in, and they make a real big difference with infectious diseases in general, which have kind of been off to the side and not getting a lot of attention until a pandemic comes around. But you know what? We still have over 100,000 people dying of hospital-acquired infections every year. Tuberculosis is still the most important disease in the world, or at least.
Oops, David, you're muted.
So sorry. Yeah, so things like tuberculosis is still going to be really important.
No, it's going to move.
I think we have too many microphones on. Hopefully that's better. And so just wrapping up my point, I think that we should realize that these other threats are there, yet we have resources to bring to bear and address them as we move forward.
Great. And Sam, could you, I know that the importance of the promotores and the CHWs. How would people get engaged with that? How, you know, because in some ways they're a substantial but a kind of hidden population or hidden resource. And Amanda, you might want to talk about that too.
Sure. The first way, so there's statewide coalitions of several employers as well as the workforce. And so we promote our training opportunities through those networks, especially through the Association of Community Health Centers, as well as our county health department partners. So ASCHEL really is that hub, the Association of Community Health Workers. They have the training center, and that's where those trainings can be accessed. And I'll put Ruby's email in the chat there. So folks, if you're interested in uptraining your workforce, or even if you do not have community health workers, ASCHEL has opened up this training for community members. that are curious or acting as liaisons with family members. So oftentimes there are folks that are very promotive of COVID prevention behavior, especially around vaccine confidence, and they act with a little bit of training, they can act to help to convince family members that might be on the fence. So that's one way that I think folks can get involved with getting the resources and the training for their workforce, as well as for community members. So it's broad, and I'll put that in the chat. And Amanda.
And I think it's important then to recognize there's a very unique aspect of the promotora or community outreach worker that has the cultural sensitivity to deliver the education and message to the families that they need to hear that, and give them the confidence and the trust that on the vaccine, on getting tested, understanding the spread of the COVID-19 prevention. We use it at all levels, from chronic disease prevention to tuberculosis or immunization. I mean, it's just across the board that you can train them. Certainly Regional Center has been a lead agency in training promotores for many years. But it is a very strong tool that you can use with the communities that you're targeting. Right now, we're working with CMS and targeting La Paz and Mojave County, because those two counties are the ones that right now we see the most resistance for vaccination and overall immunizations as well. So we're going to be working, they're setting up a focus group with local leaders who are helping assist in that process. But I think that as we move forward and continue working with CDC and CMS, will be really helpful to have an EU collaboration to target that northern part of the state.
And I want to follow on with that. We're talking about outreach that is vital to current research efforts, especially post-pandemic research efforts. We've worked with Amanda's group and incorporated their community health workers and some of their outreach folks in terms of recruiting people into our infectious disease research efforts, where we're looking at Staph aureus, both carriage and transmission, and looking at the simultaneously looking at the social determinants of health in terms of infectious disease. And it's a resource that is absolutely incredible in terms of designing scientifically sound outreach programs that get into research in very hard to reach communities. And we also all see the literature where there are underrepresented or unrepresented groups that need to be brought into the whole research process, and this is a resource for it. I won't beat it harder than that, but one of the things that we have accomplished, I think, magnificently in Yuma, and all of the universities have participated, is in this community collaboration. And our Center for Health Equity Research is kind of a focal point for managing that kind of community engaged processes. One of the things I want to do is get out the report because it shows the strength of community-based, community-engaged priorities for research that you can then take advantage of these other processes. So I'll get off my soapbox, but a big thank you.
Thank you, Bob. Any other comments from our panel? Well, I certainly want to thank you for participating this morning on this incredible discussion topic. I think it's important to bring the light around the state for the important work that you've been doing. The challenge that we faced last year, starting in March, from all of us that run rural health clinics and nonprofits like ours, was an incredible challenge to respond and protect the communities and bring the education and awareness to the folks that was so important to get tested to begin with last year. And then of course the treatment and the medical care that we needed to step up and provide. And so your research makes a lot of difference to us, that we know we're on the right track. And so with that, we're looking forward for the future, but a bright future, hopefully, that we can combat this COVID-19. And my biggest concern was the variants, and I'm so glad that David stepped up and said during one of our advisory councils to Senator Kelly, he says, I mean, we can step up and do that, and we haven't stopped since there for several months that we've been working with the law enforcement here in the Border Patrol to address the issue of the migrant and the refugees coming into our country and giving them humanitarian response to that issue. So thank you again. Bob, do we have any other words from you? I know that we're hoping that will join us again pretty soon for another discussion as we move forward with our efforts in Yuma County to continue addressing the social determinants and working with all of you. And of course, my good partner, Dr. Bob Trotter.
And my final words are thank you. This is an important ongoing process, and thank you.
And I do want to thank our translator, Elizabeth Fierros, because I cannot imagine translating this in Spanish, but she has an incredible background. They understands biochemistry, and so for that reason, she was chosen to translate our panel. We're going to take a break, and we're going to invite you to go back to the general session for our last panel speaker of the date, and we'll see you in a few more minutes if we don't have any more questions or discussions for the panel. And again, with great gratitude, and it's been my pleasure in hosting this panel this morning. Thank you.
Thank you.